morning and happy St. Paddy's Day to everybody. I hope it's a good day for you. My Irish background makes me very excited about the day, even though it's really more of an American tradition than it is an Irish tradition. But welcome to Wednesday morning mid-month training in March. Want to make sure everybody's in the right place. So if you are with us, you are here for the cultural and behavioral health track, and we've got a big day ahead of us. I will introduce our first presenter in just a minute. I want to make sure you also take time during the day to do some self-care. Our activity breaks are really wonderful. They've got exciting things to share, but they're also a time for you to get up and stretch, to grab something to eat or a cup of tea, and to come back refreshed and ready to go again. I know it's difficult sometimes to spend a whole day in front of a screen, so do take care of yourself. If you need any assistance with your tech today, please make sure you work with our wonderful team at Chase Productions, Chase AV. You can reach them at support@chaseav.com, and we will put that in the chat box for you as well. During the day, however, in terms of tech, please make sure that you're muted when the presenters are speaking. If you do want to ask questions, you have a couple of options. If the presenters welcome it, you can certainly unmute and ask a question. Otherwise, please put your questions in the chat box, and we will make sure that either the presenter or one of our staff members gets that question up so you can get an answer to that. Please do participate and interact, and please do join us for the networking lounge. We want your feedback, both in the evaluation forms, and we want your feedback at the end of the day when it's fresh and you can share what was exciting about the day, if there were any challenges, anything you'd like us to consider for future trainings. So please do come and do that with us. This morning, we have a presenter who's going to be spending a good portion of the day with you for two different reasons. She is a leader in the area of diversity, inclusion, and equity. She is also a very talented host and a person who works with organizations to make sure that you get a chance to do mindfulness, resilience training, recovery and resilience, de-stressing. She's done a lot of work around de-stressing. I had the great honor to spend some time with her virtually about a month ago, and she's very captivating, has a lot of experience and knowledge to share with you. So please join me in welcoming Ruth White to our mid-month training today. Ruth, I'm going to close down and let you take over and have the screen.
Sorry, here I am. Sorry about that.
Ruth, good morning. Welcome.
Good morning. Welcome. So you didn't hear my intro. Okay. So I was saying thank you for having me this morning. I have a couple of other workshops later today, but this one is about destigmatizing mental health among African American communities. And the focus I'm going to take on this is that providing acceptable, accessible, and affordable services is one way to destigmatize the mental health of African Americans. So I want to share a little bit about my story. So I was diagnosed with bipolar disorder about 13 or 14 years ago. And it was a challenge at the time because of the job that I had. I was a professor at the time. And when I got diagnosed, I ended up eventually spending a week in a mental health care facility that some of you at Evergreen might know, Fairfax Hospital. And coming out of that experience of the hospital, I had made a promise to myself that I was not going to end back up in a facility like that ever again. So I was really focused on how to manage my symptoms, but also to prevent symptoms. So my background is partly in public health. And so my focus is always to prevent symptoms, not just to treat them. In my search for less problematic medication, let's just put it that way, because medications, mental health medications almost always come with really problematic side effects. And some of these side effects really impacted my work. Everything from having my hands shake to having a really dry mouth to just having my brain feel really cloudy and sluggish. And so I wanted to minimize the amount of medication I took. And so I worked with my psychiatrist to I guess the academic side in me came out, and I did a lot of research around brain function, around managing stress. And why stress became the focus for me is that stress is a trigger for symptoms of both depression and mania. Stress is also the number one reason why people go to a physician. So that's how I came to the stress management work. But what happened in the process of my own journey to recovery is that I realized that one of the reasons that I was struggling to go get help, even though by training I'm a social worker and I understood why I needed to go and what the process was like. So I didn't have a lot of fear attached to going. I realized that it was a stigma, that I didn't want to seem like I was crazy in quotation marks. And so I call it coming out of the crazy closet. When I decided to do that, however, and in this slide, you'll see a picture of me on the bottom. That was a book chapter for a book that was being edited by a very prominent psychologist at Berkeley. And he had asked me, actually what had happened was I read my alumni magazine, and it was announcing the fact that he was going to be publishing a book on the stigma of mental illness, and that it had been the first book that was like a cohesive book, not just a series of chapters written by different people. And so I, being aware of my own experience with stigma, I reached out and I told him that this was something the field needed. Now, it's really interesting. I never read my alumni magazines. So anyway, he reached out and he thought that my own story, which I shared a little bit of with him, would be perfect for the book he was editing. I told him I was not interested in, excuse me, in making my story public. I just didn't think that professionally that was something that I wanted to do, because I did not want the cost of people thinking that maybe I wasn't competent to do my job. But I did get convinced because my career decided that, oh, you know what, you need writing for, you need to publish as a professor on your way to tenure. And this book was going to be published by Oxford University Press, so it was very prestigious. But I didn't know what to write. And then a friend of mine said, well, you know what, you've been keeping a journal since you're 16. Use excerpts of your journal, specifically pieces that I wrote while I was at Fairfax Hospital. And so I did that. And I did it thinking that because it was going to be some kind of textbook, it would sit on library shelves at universities across the country, and that would be that. However, as a result of me sharing this story, I got a lot of communication from people who were also experiencing mental health and also experiencing stigma. And they talked about, several of them talked about the connection of race with that stigma. And so that was the start of my journey as someone talking about the stigma of mental health. In the top part of the slide is our excerpts, our pictures from a copy of Women's Health magazine. So Women's Health magazine decided to do an issue several years ago around women and mental health. and the stigma of that. And they had found my story because I'd also written a piece for Huffington Post around the stigma of mental health in the African American community. And so these are how I got started on the journey of being an advocate for destigmatizing mental illness, specifically in the African American community, because, well, that's who I am, but also because of the impact that stigma has had in terms of whether or not people access services and the kinds of services they access, and whether or not they can access services if they do decide to ignore the stigma or take on the stigma and go to seek help. So I want to put my own experience in context with regard to these three ideas of acceptable services, accessible services, and affordable services. So, in terms of unacceptable services, the stigma that comes with reaching out to get services in the mental health sphere is felt by a lot of people, not just African Americans. But when we're going to talk specifically about why African Americans, it is a unique experience, but it is very unacceptable for us to have services that are stigmatized, that make people feel as if they're less than, that make people feel as if they are marginalized, that make people feel as if there is something so broken about them that it's not fixable. Because one of the things that happened for me around the stigma of mental illness in my journey was an incident that happened at where I worked at the time that I was diagnosed and the time I spent in the hospital. And so I I was struggling at work because, I mean, if I was at the point where I needed a hospital, obviously my mental health was not in the best shape. So I go to the hospital. I spend a week. As my doctor joked at the time, I was saner now than most of the population because I'd gotten all the drugs, I'd done all the therapy, I'd done all the things. And I was back at work. And I thought everything was fine now because just like, if I'd had surgery or something, my doctor cleared me and I went to work. Soon after returning to work, I had a meeting with a supervisor of mine, and they said that they wanted me to cancel a trip, a study abroad trip for students. And I asked why would I cancel it. So this was, I don't know, November. The trip was going to be in March. I'd spent months putting it together. Students were going to go to Germany. London, and they were going to spend a week learning about the social welfare system of London. And so I said, well, I don't understand why I have to cancel this because it's in March. Everything is fine. Students have paid their deposits, etc. Now we started to have a conversation, which was very interesting because the person couldn't come right out and say that the reason that they didn't want me to take students to London was me spending time in the hospital, because under the Americans with Disabilities Act, that would have been explicitly illegal. But what they were doing was also still illegal. It was just implicit. It wasn't direct. It was indirect. And so in my head, I was really upset because I thought if I'd had cancer and came back, or if I'd had heart disease and came back to work, if I had had a broken leg and came back to work, people wouldn't have been saying you can't do this task 4 months forward. How that got resolved is another story, but I want to bring up another incident where I met with deans at the time, and they asked me to meet with them, and they wanted me to take an extended sick leave. Now I thought, I came out of the hospital. I don't need an extended sick leave. And so we had this conversation about signing for this extended sick leave. And I thought, well, if I take off a semester and something other does happen to me where, let's just say it, I am really sick because I wasn't sick at the time, that I wouldn't have any more sick leave. And mental health episode, a lot of mental health issues are episodic, which means they come and they go. You get depressed, you feel better. You get depressed, you feel better. You get manic, you feel better. You get manic again, you feel better. And hopefully, if the medications work for you, you don't have episodes anymore. So I did not want to sign this document. And so I took it to my doctor and I said, well, first of all, they need your doctor to sign off to say that you cannot work. And my doctor said, well, I can work, so they were not going to sign it. Long story short, I was forced, and I'm going to put it in that word, strongly encouraged, is that the word, to take a sick leave. And that was devastating for my career. And this really goes back to stigma, because I felt that if I was smarter, I would not have shared that I had mental health issues. That even though some of the symptoms were things that they were seeing in the classroom, that I would have just found a way to not mention it, have a conversation that about my performance, but not necessarily about my health. During that sick leave period, I was bored. I mean, one of the things I always said back then was, if I didn't have a child, that semester off would have been amazing. I would have gone traveling. I would have seen my family. It would have just been awesome. I could have gone to Jamaica and spent the 3 months with my parents. But I had a child in school. And so it was winter, it was in Seattle, and I was trying to think, what am I going to do for 3 months? So I decided to take a course on campus. And for some reason, I ran into a student and we had a conversation about something, and I gave them some advice, and I got in trouble, and I'm going to put in trouble in quotation marks, with my boss, who said that, excuse me, I was banned from campus. And again, it hit me. I thought, banned from campus? I'm banned from campus, but can you really ban me from campus? I haven't hurt anybody. I haven't done anything. And so somebody that I know a friend who decided to remain anonymous, hired a lawyer for me. And one morning when I'm at home, the phone rings, and it's a lawyer who said they heard about my story, and that somebody who I knew had hired them, and that we were going to collaborate in challenging the discrimination that I was experiencing. And so we did that, and I didn't want to take it far, like in terms of a lawsuit or something, because I also did not want to be stigmatized as a troublemaker. And so things got resolved, but it stuck with me that if I was any other kind of illness, it would have been treated differently, much differently. In terms of inaccessibility, so let's talk about accessibility. At the time that I was diagnosed, which, as I said, was about, at this point, 15 years or so ago. Yeah, we're 2021, so more than 15 years ago. I was seeing a therapist. Some of you might know group health if you're at Evergreen, so you're in the area. So I was going to group health, and I had a psychiatrist there, and I would go see the psychiatrist. I also saw a social worker, and I also had a mental health nurse. I used to joke that it took a whole team of people just to keep my mind right. Anyway, one day I get a bill, and I get a bill from group health saying I owed hundreds of dollars. And I thought, well, what do I owe hundreds of dollars for? Because I had good insurance and it was supposed to cover my mental health. But at the time, there wasn't mental health parity. And mental health parity came legally across, health insurance as part of Obama's healthcare package and the Affordable Health Care Act, because at the time, mental health had a cap on how much services you could get. So of course, that also goes back to the stigma of it. The fact is, if you had diabetes, nobody would say, well, you can only get so much insulin, you can't get any more. Well, that was what they were telling me. And I had no idea that there was a cap on mental health services. It's important for the audience, for all of you to know that mental health parity means that it doesn't mean that health insurance companies have to cover mental health services. It does not. What it means is that if they do cover mental health services, then they have to cover it in the same way that they cover physical health services. Now, at some point at the end of this, we'll talk about, why mental health has its own category and why mental health isn't just health, right? What's the point of health if your mind isn't working? The inaccessible part also has to do with lack of providers. Now, I was lucky in Seattle that there was group health, there were psychiatrists available. And part of the reason that the psychiatrist was available at the degree to which she was for me was because bipolar disorder is considered a serious mental illness. And so I had priority to get services. However, it is a challenge for most people to find providers. For example, when I moved from Seattle to Oakland, I wanted to find a mental health care provider in the area. And I started looking. Now, remember that I'm a social worker. I used to work in a system right here in the Bay Area. I worked in residential treatment programs for adolescents. I had worked in addiction services in San Francisco as well. And I started looking and I could not, when I would find a provider, so there was a list, that comes with your health insurance, and you start going down the list, right? So you start making phone calls. And when people generally would say they weren't taking new clients, so you would hang up the phone. If they said they were taking new clients, they would tell you most of the time that they were not taking insurance. So you'd have to pay up front, usually more than insurance would cover, and then get reimbursed from your insurance company for the balance. And so it is very hard for people to access these services. Now, put on top of that African Americans in general are less likely to have health insurance. They're also less likely to be providers that are African American. And so that significantly increases the inaccessibility of services. And again, I would think that if you cannot find the services you need, you will feel stigmatized because you will feel like you are not the norm. What you are trying to access is not for you, and you shouldn't even try. The third piece is about affordability. And for me, when I spent a week in the hospital, now I had good insurance, covered, I think, 80% of my stay. What was left for me to pay was $1,000 a day. So the bill when I was leaving was $7,000. Now, that was for 1 week of care. And I remember making this little joke to the person who was, doing the discharge. And I joked that they may as well just put me back in because now I'm going to be depressed about paying this money. At the time, she said, well, there were programs that could cut my bill significantly. And so I got a 50% discount, but it was still $3,500. And I was a single mom with a child. And so it wasn't affordable. And so even if you are trying to challenge this stigma, it is really hard for you to do so if the cost of the services makes it inaccessible. So what does acceptable look like? So acceptable services means that there should be a holistic focus, especially because when you're thinking of African Americans, um, you have to take into account, or any other um, ethnic or racial or cultural group that focuses on mind body connections. It is important in the mental health space to focus on holistic services, which means you're not just focused on mental illness in quotation marks, but also mental wellness. So that people, when they access the services, understand that it's not about just labeling them with a diagnosis, which is a challenge, especially for African Americans, because if you already experience discrimination, the last thing you want is a label, is a diagnosis that will add to your list of um, status that put you at risk for discrimination. So, for example, if you're an African American woman and you're thinking, well, okay, I'm gonna go get services, but if I go, I am gonna get a label of, I don't know, bipolar disorder, or that I have anxiety, or that I am depressed. And then you think, great, now I have this other thing that I have to deal with, right? So we're talking about the intersectionality of these different statuses that an African American would bring with them um, to the treatment equation. Acceptable also means low doses of um, mental health pharmaceuticals. Now, pharmaceuticals in the mental health area are noted for um, for being problematic, right? In terms of symptoms, as I shared before. And so, for a lot of African Americans, especially because they often cannot afford to not be working, and a lot of the symptoms that come, a lot of the side effects that come with these drugs can get in the way of functioning at work. So, we need to focus on low doses. We also need to focus on support. Um, if someone does not have social support with that diagnosis, then they're not going to do as well as people with support. So if you're talking about um, an already discriminated against community, and then you further stigmatize them through um, this process of getting help, they really need support. But if they're in a community that stigmatizes and marginalizes people with mental health disorders, then they won't get the support they need. And that's oftentimes why a lot of African Americans won't go to get care. It's because of the lack of support. And there's also the issue of career success. Um, Acceptability for me also meant that um, at my new place of employment at the time, a few years ago, I because of my experience at my last place of employment, I decided I was not going to share commonly that I had a mental health disorder because it didn't play out so good for me the first time. So I thought, well, I'll just put my head down to my work and it will be fine. But I published a book called Preventing Bipolar Relapse soon after getting to USC. And I did not share. Now, academics are supposed to publish or perish. And so we always make announcements when we have published articles or books or whatever it is. So I put out this book and I said nothing to anyone. Because again, I wanted to keep it a secret because of the previous experience I had. I did not want to be stigmatized again and be discriminated against. However, my experience at USC was totally different. One day I woke up, one of my colleagues, it turned out, had discovered my book, and the faculty were having a discussion online by email about me writing this book. And one of my colleagues talked about how it inspired him to share his mental health journey with the faculty that morning. So I tend to sleep in and I wake up to all this chatter about me and my book, and I did not even know how to respond. I remember, calling my boss and saying, I don't know, should I say something as part of this conversation? Because it wasn't that I outed myself, and I use the word outed in quotation marks, but instead of, marginalizing me, USC decided to do a feature on me for the magazine that goes out to the Trojan family. So alumni, donors, etc. And so that's what acceptable looks like. That is how you destigmatize mental health. You make it so that um, it is honored as part of someone's journey, that it doesn't get in the way of their work, that it actually can be something that is praised in terms of recovery. Now, in terms of affordable and accessible, uh, my journey at in Oakland when I was trying to find resources, um, I remember thinking, okay, well, you need to find someone, because if you don't find someone, you're not going to be able to get care. You're not going to be able to get the meds you need. And so I was having a real challenge. I was calling different places. And then I remembered that Langley Porter Hospital, it's a mental health hospital that is attached to the University of California in San Francisco. And they have outpatient services. I also knew that there was a lot of pressure for people to get into those services because it's a teaching hospital, so they tend to be on the cutting edge. Yes, your provider rolls over every year as students and residents, move on in their education. But what it also did mean is that if you got in there, you paid a $20 copay and you were good. Um, and so I went to Langley Porter, called them, did a stack of paperwork to see if I was eligible to get services, because obviously they had admissions process. It was also fairly accessible on a bus line. I mean, it wasn't close to where I lived in terms of accessibility for me. I had to take public transit. It took about an hour to get from Oakland to San Francisco, but at least I could get there, and it was on a bus line. And so this was life changing in many ways because I knew that I could access the services that I wanted to access. So I just want to say that there shouldn't be, a lottery for whether or not you get the best care, right? I just happen to be fortunate to have the skills to find services because, as I said, even though I was a social worker, it was really, really hard to find services that were available, accessible, and affordable. And so I spent a lot of time and energy finding that. And so it shouldn't take that much. It just shouldn't. Um, so I want to talk a little bit about the unique experiences of African Americans and other minorities, but specifically, we're talking about African Americans in this presentation. So this diagram is from the sources on the bottom is from somebody else created it. So I just want to say it's not mine, but it's a really good infographic to show how different stressors impact diverse ethnic and racial groups. And there's racism, there's discrimination, there's violence, there's poverty. Now, violence and poverty and discrimination and racism don't just impact African Americans, but as some of you may know, because of the history of slavery, African Americans experience these things at a much higher rate than other racial or minority ethnic groups. So here are some data about, we're going to shift now to just think about some data. So I shared my story as a way to illustrate how these things play out in terms of the stigma. And we're talking about what we can do about it. So African Americans are 20% less likely than the general population. Sorry, 20% more likely than the general population to have a serious mental illness. Now, there's been a lot of discussion about the impact of racism and on mental health and the stress of racial trauma on mental health. And so these are some of the sources of this increased 20%. And yet, in terms of the utilization of mental health services, um, only 25% of African Americans with mental health distress actually access services versus 40% of whites. And a lot of that can be attributed to a lot of these factors here. As I've mentioned some of them before, but we'll get into others. So, lack of health insurance. So, African Americans have much less rates of insurance than white Americans do. There's a long history of distrust of the African American community with health services. Some of you may know about the Tuskegee experiment, where African American men were left without penicillin, and um, they were left to have syphilis to the end state, which meant that they died an early death and a very painful death because they had to experience the symptoms of advanced syphilis. There's also been history of forced sterilization. There's also been history of being lied to and being used as guinea pigs for testing of drugs, which is also tying into COVID right now, where a lot of African Americans are not trusting the system. A lot of people aren't, but at a high rate. There's also a long history of misdiagnosis because of the way that symptoms might present and the lack of collaboration between doctor and patient. So this misdiagnosis is often a result of a relationship that is fraught with anxiety and this distrust and not willing to share everything. So of course, if I go in feeling stigmatized and I'm not sure what to share because I don't want to get labeled, then it's really hard for a good diagnosis to happen. But also if I don't know much about the culture, like if I'm the provider and I don't know much about the culture and I'm not sure what this person is experiencing, then it is more likely to end in a misdiagnosis. There's a lack of cultural competence. So, and this is not just for African Americans, but we're talking about African Americans now. So that is the context of which I'm speaking. So there's a lot of cultural competence of providers around issues that are specific to African Americans, but also how being discriminated against is part of the context in which mental health is assessed and diagnosed and treated. And then there is the stigma. So some data around the mental health of African Americans. So there's increased anxiety and depression among African Americans, as are suicides. Young African American boys are twice as likely to die by suicide compared to their white peers. I thought it pertinent to discuss COVID-19, and the pandemic has hit African Americans much more harshly than it has other communities, and just like it has, for example, the indigenous communities. And that's because, the joke goes in the African American community that if white people catch a cold, Black people catch pneumonia. And that's because if you are already in a marginalized group, then whatever impacts that society is going to impact you at a higher rate because you are already at a social and economic disadvantage. And so increased economic insecurity was a big deal in the African American community because the types of jobs that they tend to do are often the ones that people had to show up. So whether you're in the service, food service industry, hospitality, etc. And then a lot of these people lost their jobs. And so that means that COVID took they got a big hit from COVID. There was a disruption of civic and religious life. So the places that African Americans would go to for social support were no longer there. The African American community is very religious, and they use faith as a way of getting through the hard times. That was not accessible in a meaningful way for a lot of people. And one of the reasons that African Americans were also experiencing COVID so severely was because they tend to live in multi-generational households. And so that was also both benefit as well as risk. Last year, there was a significant social unrest over police killings of unarmed citizens, but 2020 was only unusual in terms of the global response to these experiences. But this has been going on for hundreds of years. And so African Americans have experienced significant discrimination and prejudice and violence that is going to impact their mental health in a negative way. And I used a quote here of Michelle Obama talking to a podcast host during the COVID pandemic. And she said, I know that I'm dealing with some form of low-grade depression. Now, I'm not saying that Michelle Obama is an example of all African Americans, but it just was a quote to illustrate how a lot of African Americans were feeling. In terms of the conditions that African Americans experience, one of those things is feeling that they have to be twice as good or work twice as hard as the average American. And Americans already work really hard, right? We work so hard that by October, we have worked the same amount as what Western Europeans work for the entire year. So these are additional conditions on African Americans that put them at risk for mental health disorders, because we know that working really hard, not taking time for self-care, is going to put people at higher risk for mental health disorders. There's also the cultural identity of the strong Black woman, which is something that African Americans take pride in, that things have been thrown at us. We got kidnapped from Africa. We were forced to take a very risky trip across the Atlantic. We were slaves. We were sharecroppers. We've been discriminated against, and we come back fighting. However, that is also a stereotype that stigmatizes mental health, because it makes a lot of African American women feel as if, well, if their mothers and grandmothers, aunties, cousins have gotten through a crisis or gotten through stressful moments where they were vulnerable to mental illness, well, why can't they? So this just adds to the the stigma, because people feel as if it's a personal failure if I need help, because culturally we're strong, we survive, we thrive despite all the odds. And now to admit or own that you have a mental health problem is often to admit or own that you have a weakness. Also, there is this also stereotype of Black people being angry, and people feeling as if, African Americans feeling as if, people don't like to see their anger, even though they have excellent reasons to be angry. But if you start to think about the stigma of that, so you're feeling angry, you're feeling upset, but you don't want somebody to tell you to pathologize that anger, because there is legitimacy in terms of why you're angry. And so that's a stigmatizing stereotype. And there is also this, Black don't crack, in terms of, yes, people always say about the face and the skin, but there's also this sense that we survive, we thrive, we don't break, we don't have to go, therapies for white people, they can't handle life, we've been through all these things. It's also because of the degree to which African Americans use the church and faith and religion as support. There's also the sense that if you're experiencing something that is a mental health issue, you don't need to go to the doctor. You just need to take it to the Lord in prayer. So you need to pray, and God will help heal you. And there's been a big movement among African American religious leaders to acknowledge that while prayer is appropriate for you to seek help, it doesn't mean that you don't also go and seek help for a mental health condition, because if you can go to the doctor for your diabetes or your hypertension, then you can also go to the doctor for mental health issues. Close to wrapping up here. So when we start to think about the mental health workforce, African Americans may make up 13% of the US population, but only 2% of psychiatrists in the United States are African American. And so it means that if somebody wants to find care that is culturally competent, where they feel safe, because a lot of times, because of these things around distrust and the history and the stigmatization, a lot of African Americans would prefer to see an African American health care provider. Doesn't mean all of them do, but a lot of people do. If they want to talk about racism, if they want to talk about discrimination, they often feel that a white mental health care provider will not understand what they're talking about. And 86% of psychologists in the US workforce are white. And of the psychologists in the United States, 4% are African American. Furthermore, 21%, so we do have in social work an overrepresentation of African Americans. So almost 22% of social workers are African American. Now, if we're going to destigmatize the mental health status of African Americans, getting care is really important. So the distrust and the misdiagnosis, I talked about some of it already. Just to fill in some more, Dr. Benjamin Rush, who was the leading medical authority in the United States following the American Revolution, said, that African Americans experienced something called negritude, which was about, African Americans wanting to be white. A pro-slavery physician, Dr. Samuel Cartwright, argued that severe whipping was the best treatment, in quotation marks, for African Americans. We've experienced the eugenics movement, which said, we're less than, and so you want to get rid of African Americans. And if you had any mental health conditions, you were seen as undesirable. And so people were forced to be sterilized, and they had lobotomies, which is, if you're not it's removal of the frontal lobe. And then this idea of the culture of poverty. Now, just this year, the American Psychological Association issued a formal apology to Black, Indigenous, and people of color for their support of structural racism in psychiatry. Now, people have really responded to this. They want to see more than just an apology. And for the American Psychological Association to acknowledge this says that what African Americans were experiencing in this area of healthcare was not in their head, that it actually existed. And so now the challenge is to correct for these structural factors in race, this structural racism. And so just a bit more data, 44% of non-Hispanic Blacks are relying on Medicaid and public health insurance, which often really limits the access to mental health care, even though it's supposed to cover it. Again, there's no one forcing a provider to take it. And because Medicaid often provides lower reimbursement rates than other forms of health insurance, oftentimes it makes it harder to find practitioners. And we talked about the cost of therapy. So my 45 minutes is almost up, and I just want to say that the two key takeaways that I want people to remember as we think about mental health is that mental health is health. It is part of us being well. It is part of how we function in the world. And so one of the things that I did not have on the slides, but is something that I really push for, is for primary care providers to do mental health screenings as part of your annual checkup. This would significantly destigmatize mental health, because it would just be seen as health. It would just be something you go, just like they weigh you, they take your blood pressure, they take your temperature. they just give you, when you're sitting in the office, they ask you to fill out all these little forms. They just give you a quick assessment of your mental health so that they can refer you if you need referring, just like with other disorders. And so that would go a long way, but also to remember that health is a human right. And so people should not feel stigmatized to take care of themselves. So here is a summary of what I said. So making it destigmatize the services, making services accessible, primary care integration, anti-racist practice to make sure that it's also affordable. And so I want to thank you for having me. And I have, I guess, a minute or two. I'm not sure. I'm going to let Kathy decide if we have time for questions. So I'm going to stop sharing right now.
Hey, Ruth, it's Maureen. We do. We have about 12 minutes. So I do have one question. Do you have suggestions in ways that we can help support Blacks, African Americans, anybody of color in pursuing studies and careers in the mental and behavioral health field so that we won't have that great discrepancy in having people of color actually available to help people of color in the future?
Yeah, so I think I always tell people part of normalizing anything is to include, right? So that when you're talking about, so I'll just give you an example. I was working with a group last year that represent people with disabilities. And it's a very prominent group. It's a nationwide group that pushes for integrating people with disabilities into executive positions. So not just I have a job, but for them to excel in their careers. And one of the things I noticed when I was trying to put together my own slide deck, right, was I could not find, even during in the paid part, like, I have all these free photo websites, but even in the paid sector, like Getty Images, et cetera, it's very hard for me to find images of people of color with disabilities. And on their own website, they didn't have any images at all of people with who weren't white. And I didn't call it out to them at the beginning, but I called it out to them after I did all of the work. And I said, well, here's one way, right? So including African Americans in data, finding you did this here. You found an African American to de- de- deliver some of your training. It also means that as a resource that you provide culturally specific resources. So if you have resource lists, for example, and in fact, now that I'm thinking about it, something that I can share with you is and I will pass it on. I'll email it to Kathy and she can share, I don't know why I forgot it, but it's a list of African-American mental health resources. And that is put together by NAMI, and I added some. So I went out and also searched, but the NAMI list is pretty comprehensive. But I will share that list with you so that you can put that list on your website, for example, so that people who are experiencing some of the issues that you guys support will have access to resources that are specific for them. So I think that's part of it, is making sure that whatever you do, you're including ethnic and racial and culturally specific resources for people so that they feel like they are included, they're not marginalized. They don't have to go, okay, well, who are these people? Are they going to know my story? How are they going to interact with me? And again, I don't want it to seem like there's a monolith and everybody, white wants to see a white practitioner and Black wants to see one. But because of the long history of racism in this country, it is a unique experience for African Americans, and they often want to find someone who provides that. There's also support groups. So, you guys have support groups that you run, and maybe you want to consider running support groups that are specific to African Americans that will allow them to build community, a supportive community, and for them to feel seen. I tell people sometimes people don't even access the racially specific resources, but they feel like, look, I want to go to this program because they see me. They've acknowledged that I exist, that I have a gambling problem, and I'm African American, and I might have unique experiences, whether it is access to, financial repair services, all these different things. It makes people feel as if this agency is somewhere that sees me, acknowledges me, and is providing specific services for me. Does that answer the question?
Yeah, I think it does. Do you know, kind of an add-on to that, and I would encourage anybody else in the group to put questions in the chat or unmute and ask questions, but are there specific places where people of color, particularly African Americans, might be able to apply for scholarships if they're interested in studying mental health, behavioral health? Are you aware of opportunities
Yes.
like that?
Yes. So the National Institutes of Mental Health, NIMH, has a minority fellows program. I know several people who have accessed that program to pay for doctoral studies or a Master of Social Work studies. It's trickier at the master's level sometimes, just in terms of access, but there's also scholarships, for example, if people want to work in child welfare, which are not culturally or racially specific, but if they want to work in child welfare, there are scholarships. Trying to remember what it's called, but anyway, it's just on the tip of my tongue. I'm seeing it there, and I just can't remember the name of it. But there are scholarships, and I do encourage people to. There's a platform called Scholarly, SCHOLLY. I'll put it in the chat. It's scholarly.com, and it's actually a resource that was developed by an African American. He pitched on Shark Tank, got money, and it's probably like one of the biggest sort of platforms for exploring scholarships of all kinds for everyone. So you put in, that you're African American, and it'll provide you with scholarship opportunities that are specific. But yes, there are also scholarships for white people who want to provide services for African Americans. So if they want to study certain kinds of topics related to African Americans, there are scholarships. And there's more that are coming on board as one of the things to note is that in psychiatry and psychology, this is an aging profession as well. So especially in psychiatry, I think something like the median age is like 55 or something. So when you start considering the mass retiring that's going to come in the next decade, it really behooves the medical profession to provide a lot of support for getting more doctors, because psychiatrists are doctors, to getting more doctors trained in mental health. Because we're just talking a shortage overall. So if you're talking a shortage overall, right, and you're living in a marginalized community, like in Oakland, San Francisco, there have been studies that show, that, and across the country, that in predominantly white neighborhoods, there's a huge access to mental health services in African American communities. And, we must acknowledge that in the United States, these communities are often marginalized. There are, segregation is huge across the country where Black people live in Black neighborhoods due to redlining and all the history that I don't need to go into. But all of that stuff has meant that African Americans tend to live in highly concentrated areas. And in those areas, there's lack of resources. So again, it's not just providing resources, but where are those resources and how accessible are those resources as well? I also see that you are talking about, and yes, so I also think that, there needs to be a concerted effort to reach out, recruit, share with people models. Like, if people don't know what a psychiatrist does and they don't see anybody like them in psychiatry, they're going to go do something else. It's why social workers are so heavily, why we have an overrepresentation of African Americans, because that is a profession that people know, are familiar with. It's easier to access than, psychiatry, et cetera. It's a much less expensive. You can go to a state university, get an MSW, go on to get licensed and, all of that. But it's a much longer and much more expensive haul to do medicine and psychiatry. And yes, Maureen, when we're talking about what the APA is actually doing, so they came out with the apology in January, and it was interesting. I stumbled onto it because I was preparing another slide deck and I was Googling something else, and I found the apology. So I don't know how come it didn't end up in my, social media feeds, but everybody's sort of going, okay, now that you've done that, what are the steps they are going to take to address these issues that are significant in terms of the history of the profession?
Great. Anybody else have a question for Ruth? If not, I'll ask one more.
Okay, go ahead, Marie.
You mentioned that often social work is easier to access than perhaps psychiatry or psychology.
Mm-hmm.
Are there other places in African-American communities where people are more likely to seek assistance first? I'm thinking family members, I'm thinking churches, I'm thinking athletic coaches. Are there others we should be partnering with to reach out to this community?
Well, the faith community is huge. And there have been some initiatives that have been started to normalize mental health care. There was one campaign that provided information through barbershops, for example, and hair salons, which is a place that African Americans go, and it's destigmatized because it's out in the community, and they were training people to talk about mental health, as well as, I would say the other thing is to train people in mental health first aid so that they can provide some services in the paraprofessional realm to their family members, to people in their community. But definitely faith communities are one. Youth programs, like the Boys and Girls Club, for example, is a great place for adolescents to learn that it's also okay for them as they struggle through the challenges that come with adolescence. We were all teenagers once. We know what that can look like. And they're under a lot of stress these days. And we know that there's much higher rates of anxiety and depression than it used to be. And people are talking about, the pressure of college and all of these things now. And so I also think that if we start while kids are young, then they just see going to therapy as the same as going to get your broken leg fixed. And so you can normalize it while they're growing up so that when they're an adult, they're not challenged. There's also, there's one group called Men to Heal, which was started by an African-American man to encourage African-American men to seek help and to share, not just waiting until they have symptoms of a mental health disorder, but how do you prevent it? How do you share in community? How do you make it okay to say, I'm not okay? How do you make it okay to say, I need you right now? And can you talk about this thing that is bothering me? And so normalizing those things as well will not only destigmatize, but it will reduce the incidence of mental health among African Americans. Because, if you think about that higher rate, that I shared, 20% higher mental health incidence in African American communities, if you think about all the risk factors, but then you think about, well, if it's stigmatized, I'm not even going to share with my cousin. I'm not going to share with my mom. I'm not going to share with my sister, right? So then I end up, when I do go get help, I'm farther along the trajectory of symptoms than if it was normalized for me to just say, I need help, and somebody's like, okay, I got you, right? And it's not that a friend or a family member replaces mental health care services, but if you can get support early on in a distressing period of your life, then you're less likely, to have to need mental health care services. Okay. Oh, wow. Thanks, Richard. That's really interesting. Yeah, so it's important for people to reach out. I tell people Google is your friend, that, for African Americans who want to get into mental health fields, there's also licensed professional counselors. There's, marriage and family therapy. There's all these different avenues that people can take that all provide different scholarship and funding resources.
Well, this has been fascinating. Thank you so much, Ruth.
Thank you.